All right, so I chose the topic of sex addiction for my project. Um, it's an extremely fascinating topic, and I wish I had more time to go in depth into some of these concepts. Um, Unfortunately, there just isn't enough time. So, if any of you are interested in this topic, feel free to email me. I read through some upwards of 20 some articles on this topic. So I do have a lot of research on this for anyone who's interested. So you can feel free to reach out and I can pass that along. So we can go ahead and get started. Hypersexuality disorder and sex addiction are kind of used interchangeably in the literature. Now, when you dive deep into the research, you'll find that not everyone agrees with this, and that many contend that the sex addiction and hypersexuality disorder are different in their etiologies. But for the purpose of this presentation, we're just going to use them interchangeably, just to keep it simple. So it's defined as a pattern of excessive preoccupation with sexual urges, fantasies, behaviors that a person struggles to control that results in negative consequences and a negative impact on their life. It's estimated to affect approximately 2 to 10% of the population. Getting exact prevalence rates can be difficult because it's assumed to be underreported because this particular addiction carries such a negative connotation with it. Also, it's not standardized across the board. And it can be conceptualized a little differently depending on who you ask because it is not included in the DSM 5. It was originally included in the DSM 3, but I believe it was originally conceptualized as more of an obsessive compulsive based disorder, and then it was removed from the 4, and then it was pitched to the APA for inclusion in the DSM-5, but it ended up being rejected. However, it does appear in the ICD-11. Now, in terms of comorbidity, it's often seen paired with other disorders, the most common being ADD and ADHD. So out of all the people who meet criteria for this proposed disorder, approximately 50% of them will also meet criteria for ADD or ADHD. It's also commonly seen with drug and alcohol addictions. So you see 40 to 50% of those who meet criteria for HD also meet criteria for a substance use disorder. 38% for eating disorders. And gambling addiction is interesting because only 5% meet criteria for a gambling addiction. And that's interesting because many researchers agree that hypersexuality disorder and gambling addiction have similar roots, with their etiology, even the way it affects the brain. In brain imaging studies, they look extremely similar. It's also very comorbid with mood disorders, anxiety disorders. Depression and anxiety are very common because of the nature of this disorder, its etiology, the trajectory of the addictive cycle itself. Other researcher has indicated that it's also comorbid with certain personality disorders or traits like narcissistic, antisocial, obsessive compulsive personality disorder. Some traits like perfectionism are very common. Impulsivity, negative self-image. People with this disorder also tend to be very psychologically rigid. So there's that lack of psychological flexibility, which kind of goes hand in hand with this experiential avoidance that we're going to go into. There are a few theories as to where this disorder comes from, but the most widely agreed upon attributes it to disorganized attachment and attachment ruptures in childhood. Sexual abuse is very common. 97% of people who meet criteria for this disorder report childhood trauma or sexual abuse of some kind, which is higher than any other addiction problem. Attachment ruptures can lead to an insecure attachment style as an adult, and issues with emotional regulation that result from this childhood trauma and neglect contribute to the cycle of addiction. So a person will use sex as a self-soothing strategy, a coping mechanism to help with these feelings of depression and anxiety. Shame and guilt are really central to this addictive cycle because they reduce a person's motivation to break free of the cycle. You know, you engage in sexual behaviors in order to avoid unpleasant emotions. Then when you're done, you're left with feelings of shame and guilt, which, you know, people are not going to be motivated to break free of the cycle when they experience that. The logical conclusion for them is to simply engage in the behavior again to continue avoiding those feelings of shame and guilt. So it, you know, helps perpetuate the problem and continue the cycle. And the cycle is reinforced through operant conditioning. Both positive and negative conditioning appears here. So the sex act itself is positive reinforcement. The removal, or rather pushing aside the negative emotions, acts as negative reinforcement. And this is just a diagram from a proposed, what they call sex behavior cycle of hypersexuality that we're not going to go into, but if anyone is interested, I do have the research for this that I can pass along. And I'm also not really going to go into this diagnostic criteria in depth. I'm going to provide it as a handout, so feel free to look it over. It's fairly standard and in line with how other disorders are diagnosed. And this is just a little screening tool that people can use. Questions to ask your clients to kind of tip you off if they might be struggling with sex addiction. It's important to note that because of the high levels of comorbidity, it's important to be asking these questions, because if you're only addressing their addiction of choice or one addiction, you risk kind of ruining the client's progress, because often you'll see in the addictive cycle that when one addiction is removed, it'll just be substituted for another one. So maybe someone will start engaging in addictive sexual behavior, which can then cause them to backslide and start the cycle over again with maybe their addiction of choice. So it's important to be screening for this if you suspect that a client might be struggling with addiction. So I'm not going to go too in depth with how this applies to men, simply because the majority of the research focuses on men. And this is because it's assumed to affect men at a higher rate than women, although not all of that research is in agreement. So we're not really going to go into depth with this. Now, how it applies to women is a bit more interesting, because some researchers have asserted that it actually affects women at an almost equal rate as men. And many have theorized that the prevalence among women is underreported because of the more negative stigma assigned to women when compared with males. Women are in a unique position when it comes to sex because of the messages that they're fed beginning in childhood. Specifically, you know, we're talking about religiously based messages, specifically Christianity. So we see a lot of shame surrounding sex with women because of these polarizing messages that they're given since childhood. So women are, you know, expected to sort of embody this Virgin Mary type archetype, and while simultaneously being told that they also need to be able to find a way to embrace the Mary Magdalene or the whore at the same time. So this can be very polarizing. It's sort of a dichotomy where they're expected to portray themselves in one way, but are also being told that their responsibility is, you know, to essentially please a man. So they're under a lot of added unique stress that's born out of this sort of religious context. It's, hypersexuality is also commonly seen with borderline personality disorder, which is, I'm sure you all know, has been historically viewed as a feminine personality disorder. It was originally conceptualized as hysteria. And since the etiology is generally regarded as being rooted in childhood trauma, women who meet criteria for this disorder report a much higher rate of childhood sexual abuse and trauma when compared with male populations. And this is in part because if we're talking about sexual abuse within their family of origin, incest between father and son is a lot less common than between father and daughter. Research being conducted on prison populations has indicated that certain pharmacological interventions can be effective in treating this. Specifically, SSRIs have shown to be very effective. Anti-androgens, AAs, are very effective at lowering testosterone levels. Hormone agonists are also very effective, although they are a little more hardcore, so they're not as widely studied or utilized. This study in particular was conducted in the UK and showed that pharmacological interventions were able to reduce hypersexuality and compulsivity in the offending populations after only a month. And those levels continue to drop up to about 6 months is when it started to level out, bringing those sexual fixation levels down to be about equal to what you would see with the average male college student. Now, I wanted to address hypersexuality and how it applies to gay and bisexual males in particular because it's estimated that they make up the largest portion of people affected by this disorder. And part of that, it's been theorized, can be attributed to a sort of sampling bias because a lot of this research is conducted using internet resources. And because of the nature of homosexuality and how it's viewed so negatively, this means that more gay and bisexual males are more likely to seek out sexual encounters through websites or dating apps. So that can also contribute to the sampling bias. Now, it's hard to boil down minority stress theory into just like a minute. I've been studying minority stress for a few years, so I'm going to try and keep it very basic. So it helps explain the higher prevalence rates for gay and bisexual males because this population is subjected to higher levels of discrimination, added stressors, negative childhood experiences, bullying. These stressors impact a person's ability for that emotional regulation and results in increased levels of depression and anxiety, which, as we know, are huge components and driving factors behind the sexual addictive behavior. Now, when it comes to couples, obviously this addiction can have a detrimental effect on a relationship, and it's recommended to take a both and approach. So this means having the individual who's struggling with this in individual counseling, working on the addictive component there, while in simultaneously doing couples counseling to work on how they relate to their partner. So it's usually 10 to 25 sessions over the course of 3 to 12 months. The person struggling with HD is responsible for working on their fixation, where the partner is responsible for being a supportive and non-judgmental partner. So they're not there to police their partner's behavior because that just further contributes to the guilt and shame that keeps them mired in this cycle. So the couples counseling really works on helping the couple redefine their sexual relational style and their communication with one another. So it's recommended to do all this at once along with group therapy. Now, the research prioritizes group therapy over 12-step groups. And they actually recommend that you do both if it's feasible. But if you're only going to do one, they recommend group therapy because you get more of that self exploration that you don't get in 12-step programs, which are peer led. So we've covered some interventions, pharmacological interventions, couples counseling, group counseling. Others recommend a sort of integration of different therapeutic elements. So you're trying to attack different components of the disorder all at once. So, since it's rooted in childhood trauma and attachment issues, narrative based therapies have shown promise in helping the clients kind of explore those cognitive affective distortions from attachment issues and how they can become eroticized as adults. CBT, cognitive behavioral based therapies, have demonstrated efficacy in coping with distorted cognitions that can keep the client stuck in the behavioral patterns and the addictive cycle. Mindfulness interventions are good at helping increase their emotional tolerance. So we're looking at that experiential avoidance with that. ACT, DBT, Gestalt interventions have also been recommended. If there is an OCD component, then exposure therapy with response prevention is recommended. One of the tricky things doing attachment therapy is that you're trying to teach the client a healthy attachment style with you as a therapist so they can apply that to their life, but they're going to have trouble doing that. You need a strong rapport with the client, but it can take a little longer for these clients because these relationships are very difficult and painful. So they simultaneously crave connection, but it's also frightening. It's terrifying for them. So meeting the client where they're at, allowing them to sort of attach at a distance, if you will, until you've really built up that rapport is really important. Clinicians agree also that, somatic healing is very important when working with this population, approaching it in the here and now, helping the client realize what's going on inside of your body right now. What are you feeling? Because these are feelings that the client has worked very, very hard to avoid. Helping them grieve those early losses in childhood with their attachment issues. So the neglect, the abandonment, the abuse and rejection, and helping them to repair relationships with their family of origin if possible. Many clinicians have said that drawing a genogram can help in exploring their childhood relationships and help track their attachment issues and asking them detailed questions about their family of origin. Clinicians also have to be aware of how they monitor and handle erotic transference and countertransference, because that can lead to new attachment experiences for the client. So just keeping in mind that the whole goal of working with clients on this issue is modeling that secure attachment with the client so that they can then take that and apply it to relationships outside of the therapeutic space. Something else to keep in mind is that as a therapist, you're trying to help the client to feel their emotion for what it really is, rather than using sex as a way to disengage from difficult emotional experiences. This can be challenging for those struggling with sex addiction, especially because alexithymia is very common, being cut off from those emotions. One of the clinicians in this article said that addicts don't know that they've got feelings because they've spent their whole lives trying to avoid them. So that's essentially it in a nutshell. Again, if anyone is interested in this topic or something caught your fancy, you can go ahead and feel free to reach out to me. I have quite a bit of research connected with this topic that goes much more in depth. Specifically, the etiology of the disorder is incredibly fascinating and also, in my opinion, very applicable to other disorders that you'll come across. So if you are interested, feel free to reach out and I can go ahead and hook you up with the material.